Okay, so let's start off this webinar. Of course, the title of the webinar is how photobiomodulation, or of course laser therapy as it's most commonly referred to, can potentially help heal or at least treat labrum tears, cartilage labrum tears of the shoulder and the hip. During my research for this webinar, I probably could have easily made this 2 webinars, but in fact, I've done 1. So it will be, there's a lot of information here. And I thought it was an interesting topic, and the main reason for that is the relatively common conditions. You will see this in your clinical practice, and they're notoriously difficult to treat. So adding laser therapy, it definitely can be helpful with an understanding of what you're trying to actually accomplish or achieve. So remember that these webinars are recorded. You can always watch it again later if you're not able to actually attend in person or have to leave earlier or what have you. And you'll get a follow-up email with a link. Please ask questions as we go along in the Q&A box, and I'll definitely get to those at the very end of the lecture as well too. And again, I'm always open to ideas or topics for webinars. So if you're thinking about ones or have ones in mind I haven't covered, let me know as well too, because that's something that allows me to get more information out to you guys as well. Okay, so I will cover a bit of the anatomy and pathophysiology and etiology, that kind of thing, of both shoulder and hip labrum tears. And then I'll discuss the different mechanisms in general, how photobiomodulation or laser therapy can be helpful for these conditions. And then specifically, I'll talk a bit about the parameters that you should be using, or at least a baseline to start with, along with some other tips for treatment, and then some other options out there for your patients as well too. And of course, we'll have time for Q&A. So let's start with the shoulder. You know, the shoulder joint itself is a very shallow socket type of joint. Labrum is a fibrocartilage rim around an acetabulum. In this case, in the shoulder, it tries to give a little bit more depth. It's triangular in cross section, and the thickest portions at the circumference of the cavity and the free edge is, generally speaking, sharp and thin. So as it comes out, it narrows into this sharp, thin aspect, and unfortunately, that's what kind of makes it easy to tear as well. It is continuous above with a long hit of biceps, and keep that in mind because that's one of the mechanisms of a slap lesion or a superior labral tear. It deepens the cavity to help with articulation, even though it still ends up being a very shallow joint, and it's lined by a synovial membrane, the synovial membrane of the joint cavity as well too. If you look a little bit closer at the anatomy, especially the long hit of biceps brachii, you can see how that long head comes in and attaches around that glenoid labrum ridge. So that's really important to understand that, because that's the area that oftentimes you're going to be treating in the case of a slap lesion, the most common labral tear in the shoulder. And if you look at the shoulder joint itself, you can see that it's a very shallow, small area of articulation of hyaline cartilage along with that labrum surrounding the joint itself. And there's just another picture. I like this one because it shows you the articular cartilage. So not a whole lot of articulation really with the humeral head. And then you can see that labrum. I know it's kind of hard to see, but it's quite thick where it attaches to the bone and then thins and narrows as it comes out to the periphery. So labrum, as I mentioned, is relatively soft cartilage. It's going to encircle the entire glenoid cavity and provides protection and stability. Now, tear can occur anywhere along the labrum as it connects to the glenoid region. Common causes, as you would suspect, would be overuse, degenerative changes, that kind of thing, trauma. So in general, labral tears of the shoulder make it weaker and less stable. Patients will complain of certain symptoms I'll talk about shortly. So it can become unstable, and this is problematic because that can lead to shoulder dislocations, that kind of thing as well. Different injury mechanisms will cause different tears depending on the location in the labrum itself. And the site of the tears are usually described when you're looking at the glenoid face as a clock. So 12 o'clock, to 3 o'clock, 6 o'clock, and 9 o'clock. So that's usually how orthopedic surgeons refer or reference where the tears are, or radiologists as well too. So if the tear is at the front of the shoulder in the anterior sort of 3 o'clock to 6 o'clock region, it's called a Bankart tear. When the tear is at the top of the shoulder or the superior region from 1 o'clock to 11 o'clock or thereabouts, that's referencing a slap tear. Again, probably the most common lesion, labral tear in the shoulder. Less common is when the tear is in the posterior aspect of the shoulder, 6 o'clock to 11 o'clock position. That's called a reverse Bankart tear. And then finally, if you have a tear almost around the entire glenoid region or around 270 degrees thereabouts, that's a combination of all these tears, quite a significant tear, and that is known as a combination tear or 270-degree tear. Symptom-wise, when you're looking at these types of tears, obviously there's usually pain. So the person may also experience other symptoms like popping or grinding sensations when they're moving the shoulder. It can be catching or locking. Typically, you'll see a decreased range of motion. So some of these symptoms are symptomatic of other conditions. And in fact, it's not uncommon to find a labral tear along with other issues like impingement syndrome or rotator cuff tendon tear, those kinds of things. So usually having good imaging is helpful to really understand what it is you're treating. Loss of range of motion or decreased range of motion. I mentioned instability. Of course, it's going to be loss of strength, usually associated with that pain. So as I mentioned, this is very commonly occurs with other injuries, like especially the biceps tendon, because it attaches to that labral region as well, and dislocation and rotator cuff tendinopathies as well. With respect to the hip joint, that's obviously a more stable joint, a much deeper socket, greater articular surface area. And again, similar, the labrum will cover around the acetabulum to increase the depth and provide support and protection. Similar to the shoulder, is triangular shaped, obviously same type of material, fibrocartilage, and it's going to attach around the entire perimeter. I like this picture because it shows you a cross section. It can show you how it's thick on the attachment of the acetabulum and then narrows and thins. And you can see how it adds to the actual acetabulum fossa in order to increase the stability of the hip joint, which we of course know it's an extremely stable joint compared to the shoulder joint. The labrum itself in the inferior aspect is incomplete. It attaches to the transverse acetabular ligament and functions again to deepen the acetabular fossa and increases overall the surface area of articulation by about 22%. So obviously it will function to seal the joint fluid in the fossa, helps to more evenly distribute compressive forces of the hip or the articular surfaces. And the labrum itself is larger on the anterior aspect. And usually you'll see tears more in the anterior aspect. Labrum itself of the hip is susceptible to traumatic injuries from shearing forces, so twisting or pivoting or falling, or some of the mechanisms associated with tears of the labrum. It's not uncommon, by the way, for patients to have labral tears, they don't even know it, and that's more due to degeneration. But direct trauma, there's usually, usually can associate cause and effect there, like a motor vehicle accident. There can also be impingement going on, degeneration like osteoarthritis or rheumatoid arthritis, not uncommon to occur secondary to childhood disorders like leg calf Perthes disease or congenital hip dysplasia or slipped capital femoral epiphysis as well. As I mentioned, most tears occur in the anterior superior quadrant. It's really important to understand where the tear is, because if you're trying to direct laser therapy to it, then you really do need to. Sorry about the odd beeps. It's my computer. I can't turn the volume down on my computer. So apparently some people want to talk to me, but they'll have to wait. So that's why you hear a dinging once in a while. So the most common mechanism for a labral tear is an external force in a hyperextended position. Also, microtrauma is believed to be responsible for labral lesions where pain develops gradually. So the person starts to feel some niggling in their hip, you know, they probably have arthritis, that kind of thing. That's usually due to a specific kind of sort of degeneration, similar to the meniscus where you have sort of degenerative tears. It's very similar in the fibrocartilage of the labrum as well, where you'll get a fibrillation or degeneration of the labral itself. So pay attention to that, because these things are nasty and difficult to deal with, and you actually really have to know where your anatomy is to appropriately treat it. These tears are relatively common anywhere from young children all the way up to the elderly, but most commonly in the 4th decade of life. Seems that women are more susceptible than men, probably due to mechanical or angulation reasons. And this is a high percentage, up to 55% of patients present with symptoms of the hip, that when they present with symptoms of their hip or groin area, is actually due to an acetabulolabral tear. So sometimes you're thinking a differential diagnosis like an adductor strain, that kind of thing. So you want to palpate deep into the hip joint, maybe get some imaging to really sort out what's going on there as well too. However, up to 74% of hip labral tears cannot be attributed to a specific cause or an event. So not necessarily associated with trauma, or at least a trauma that they can remember, which, let's face it, a lot of athletes or people doing stuff, they don't really think about all the stuff that they've been through. And then one day they go, I have hip pain. And it's like, yeah, it was actually probably because of that soccer incident or football or tennis or whatever sport they're playing or what have you. So hyperabduction, twisting, falling, or direct blow secondary to an MVA, those are the common mechanisms with respect to a mechanism due to trauma. Women, especially runners, professional athletes, participants in sports that do require frequent external rotation, gymnasts as well, probably throw that in, and or hyperextension, definitely at increased risk of a labral tear in their hip. And interesting, I thought this was a really interesting little note here, is that those attending a gym, so if you work out a lot, that kind of thing, have an increased frequency of developing a hip labral tear. And if you think about doing squats, for example, certain exercises, you place a lot of stress on the hip, and you push through it, sometimes just because no pain, no gain kind of thinking, but that that may not always necessarily be the best approach. I'm not a huge fan of some of these things like CrossFit, and the reason for that is they tend to push themselves past their limit. It's one thing if you're a professional athlete, understand your limits and train to it. Another one that, weekend warrior or what have you. So that's my little, my little tidbit for that. Clinical findings of acetabulolabral tears in the hip tend to be fairly highly variable, but usually you're looking at groin pain. And aside from these acute traumatic events that you can obviously figure out what's going on, the symptoms may actually be fairly subtle, and may just be sort of dull activity induced or positional pain, and it just doesn't seem to get better. It continues on and maybe progressively gets worse. Patients oftentimes will describe sort of a deep discomfort in the anterior groin or lateral hip. So again, you're maybe thinking, what other things can be causing this? Like a iliotibial band tract syndrome, or even trochanteric bursitis, those kinds of things. So make sure you check all that out. And again, clicking issues going on in the hip, that may be one of the symptoms as well. So you're looking at differential diagnosing this snapping iliopsoas tendon condition as well too. So the anterior tear will obviously have pain situated in the anterior hip. And again, this is by far the most common. And they tend to be what's referred to as radial flap tears, so disruption of the free margin of the labrum. It's important to understand how much of a tear there is, because if it's significant, they may require surgery. Surgeons, they do try to repair these things, but it all depends on the severity, underlying pathophysiology, that kind of thing as well, before they'll go under the knife. And then there's something called radiofibrillated. These aren't all the different types, but I'm going to mention the most common. Radiofibrillated, which is just fraying of the free margin, more associated with osteoarthritis or degenerative changes, similar to in the meniscus of the knee. Okay, so how does photobiomodulation help? Many of you have seen this particular diagram. So it's going to help in many different ways, including improving circulation to the area. Cartilage, of course, or fibrocartilaginous tissue doesn't necessarily have direct blood supply, it gets it through nutrition, but if you can increase the blood flow directly and indirectly to the hip joint, that's only going to help. For the repair process, it can stimulate fibroblasts and myofibroblasts to help repair. So that's important. It actually can also stimulate cartilage production and repair that way as well. Of course, if there's issues with muscle, which oftentimes there is some atrophy or issues because of the pain or decreased activities, it may be very helpful for that. It's well known to help reduce pain secondary to inflammation and other analgesic aspects. We'll talk about that very shortly. Of course, bone and nerve don't necessarily get factored in here so much. Remember that photobiomodulation effects there's two mechanisms as far as how it's going to help these conditions. One is directly. So if the light can get directly to the injured area or diseased area, then those cells absorb the light and help these cells recover, regenerate, repair, improve ATP production, increase their mitotic index, and will help these cells recover to some degree. So that's a direct effect. You need to get the light directly absorbed. Problem is the depth of the joint. So there are some techniques and things you can use to try and get the probe directly or close as possible to these areas, but it depends on the size of your patient and other things as well too, and I'll talk about that at the end. And indirect, we specialize in the indirect or systemic effect as well here at Meditech and with BioFlex, because we treat the area around the lesion, in this case a labral tear, with large surface arrays of light. So this light isn't directly going to be going into the hip joint, just far too deep for that with these arrays, but it will stimulate the blood, perhaps even some bone marrow, depending where you place it. And this will stimulate white blood cells, platelets, stem cells in the blood. And this, of course, will be carried in the circulation, eventually to the hip joint and the areas that are inflamed, deep to that. So kind of a cascading depth of effect to help these tissues heal as well. It does help with pain. I mean, of course, it's nice to have decreased pain, but the goal with photobiomodulation is to accelerate healing as best we can to reduce pain. But you can get analgesia through reduction of anti-inflammatory mediators. You may also impact the pain nociceptor transmission as well and get some temporary blockage of pain that way. But we also know that research has shown that you can induce the release of endorphins and kephalins to help temporarily with pain as well. This is a little bit, a little over the top maybe, but if you look at some of the molecules that are known to respond to photobiomodulation and their biological effects, you can see that it has a great impact on certain cytokines, chemical factors, from inflammatory to anti-inflammatory to smaller molecules like ROS, ATP, calcium, those kinds of things. And I've talked at length about this in many other webinars, so you can always watch those as well too. But these will definitely have an effect on the cellular level as well. Okay, so let's talk specifically about how are you going to use the BioFlex equipment. Of course, I mentioned we have a large surface array. Those of you that use BioFlex are familiar with this. Those of you who are new to it are just checking this out for the first time or what have you. By the way, these webinars, I think, are valuable even for someone not using BioFlex. My goal here is education, not to make you buy something. If you choose to buy something, then that's great. I eventually continue to get a paycheck here, so that's always helpful. But of course, the goal here is to spread the news and education of photobiomodulation. So if you have other devices, you can use some of this information for sure. Some of it may not be overly relevant when it comes to certain protocols. I've used lots of different types of equipment, and some is better than others for sure. The fact that BioFlex has a lot of advantages, especially the systemic effect and the clinical know-how or expertise of 30 years of treating with all these conditions with Dr. Khan, I think that gives us a much greater advantage in my opinion. Looking at the shoulder protocol, There's stages 1, 2, and 3. I recall a question at the very beginning of this webinar. Someone had asked about when you would go to stage 1, 2, and 3. Now, I do recommend that you take the basic certification training because that does talk a bit about how you're going to navigate these stages. But in general, you're always going to start with stage 1. Now, if it's an acute scenario, so a lot of fresh acute pain, one can use the inflammatory protocol. If you're not familiar with this protocol, and in general, if you're not familiar with some of these protocols in general, most are embedded in your software. Depending on when you purchased and your geographical location, some may not be available. And if you'd like the complete set of protocols and you have our equipment, email me and I would certainly get out the manual that has all the specific protocols for that. Now, if we look at the shoulder protocol, you can see that it starts off with, when you're using the dual array, red continuous wave, and the infrared is set very low at 10 hertz and 50% duty cycle. That's the low end of the range there. You can go all the way up to 20 cycles per second and 60% duty cycle in stage 1. So I would recommend that when you start off with this protocol, and if the patient's not responding after a week or so, then increase and customize the parameters in the stage 1 up to 20 to maybe 60. So that way there's low stage 1 and high stage 1. And then same thing, if the patient's not responding, then you can go up to stage 2. Remember, it takes some time to respond. They're not going to respond in a session, especially a labral tear. So you got to be realistic here. And eventually you're going to do the same thing with stage 2 and stage 3. So the inflammatory protocol, by the way, you can use this anywhere in the body where obviously there's an acute scenario going on. You just want to calm things down. And I'll talk a bit about how you might add that into the treatment plan at the very end. Placement-wise, again, this is covered in the basic certification training. Generally speaking, for a labral tear, you want to place a shoulder over the anterior aspect of the shoulder to cover the coracoid process and the anterior portion of the joint. In A, it doesn't show that very well, but that's what that's supposed to show. It's supposed to actually drape more anteriorly. So you want to definitely over the coracoid process and the biceps tendon, and obviously where the labrum is. The second position is laterally. There's different ways of positioning it, but this is going to go superior laterally. So you're going to, I don't know if I would use this position. I would do it more so it's parallel to the shoulder joint, and that way you start up here over the supraspinous fossa, and then drag it over so it covers over the lateral aspect of the shoulder joint. Oh, that's showing C. Okay, sorry, that's showing C, and B is posterior aspect. Again, these diagrams, I don't know, they're not that great, but I guess I maybe should have tried to draw better ones. Well, these ones were what were available, but so again, I'm going to go over that again. So anteriorly to cover the anterior aspect of the joint, laterally to cover the supraspinous fossa and directly over the lateral aspect of the joint, and then posteriorly over the posterior aspect of the joint. Remember, you're trying to cover around the joint, not so much the muscular tissue. Now, this is where it gets interesting, because to have a direct, so by the way, and I'm sure everyone realizes, when you're using these arrays, you're not getting light directly into the joint. What you're trying to do is stimulate the blood, as I mentioned earlier, and get a systemic effect. The more placements you have surrounding the circumference of the joint, the overall better efficacy you'll actually achieve. Now, when it comes to the laser probe, this is where you have to pay special attention. There are recommendations for how many joules per point when you're treating something like into the shoulder joint. The recommendations are about 4 to 8 joules per point. So understanding what a joule is and how to do that calculation is pretty straightforward, depending on your equipment. Our equipment is close to 200 milliwatts. So that's roughly 0.18 watts. So if I multiply that by 1 second, and that gives me 0.18 joules. So if I want to have approximately 4 joules, I want to hold that probe for about 22 seconds. And then 5 joules is 28 seconds, and around 30 seconds or so is going to provide 6 joules, so on and so forth. I would start at around 4 joules, and you're going to hold the laser probe at specific sites to try and target the labrum. That's your goal here, right? Your goal isn't to treat trigger points. I mean, you can do that, but the goal specifically is to treat the labrum, all right? So palpate the coracoid process, move superlaterally and superinfralaterally to project around the acetabulum area. So you're going to have to understand your surface anatomy. You know where the biceps tendon is. Okay, you can see it right through here. So it's going to be medial to the biceps tendon, lateral to the coracoid process, and then you're going to palpate up and down that area. That's usually quite tender, especially where the biceps tendon is coming in as well. So use that as a guide. So you're going to put the probe on, hold it for that minimum amount of time, and then move it to the next point, approximately a centimeter or so or thereabouts to the next point. And so you should be able to get maybe 6, 7 points in through there to treat that specific area, give or take, right? So total treatment time with the probe might be as long as 5, 6, 7 minutes, 8 minutes to try and get enough energy directly to that labrum. Let's move on to the hip. We only have about 5 minutes or so left. The hip protocol, you can see here, it's much longer, 8 minutes of red, 10 minutes of infrared. That's almost 20 minutes per placement, and there's 3 placements. Super long treatment because it's a super big joint. Now, our new equipment, the dual and multi-port, by the way, has the capacity to treat multiple areas at the same time. So with the new dual port, you can treat 2 areas at the same time. With the multi-port, you could actually treat the entire hip joint at one shot if you have 3 arrays in the multi-port, which means that you can do the entire hip joint in 20 minutes with the arrays and another 8 or so minutes. So you're looking at around 30 minutes or less, as opposed to about double that, just using 1 array at a time. So there's a huge advantage to that as well. If you have our first generation equipment and treating 1 at a time, then of course this is a much longer treatment. Of course, it is hands-free 90% of the time. I do get a lot of practitioners that are interested in the equipment and they balk a lot because they don't like the treatment times. And I try and explain to them that treatment times are there for a reason. The research shows that longer treatment times are more effective. So you can treat faster, you just won't be as effective. You can use a class 4 and not be as effective, or literally not do photobiomodulation. So really you need to understand what it is you're trying to achieve here, and you need to be patient. So treating for longer periods of time is definitely beneficial. You just put it on your patient, go to your next patient, do stuff, or have an assistant move it around whenever they need to. So it's not challenging to incorporate into your practice. Looking at the protocol, it's 50 hertz, a little bit more stimulation, and 70% duty cycle in that stage 1, moving up to 50-90 in the high stage 1. So start off with stage 1, move to the high stage 1 once you plateau or patient's not responding, and then move to the next stage and do that similarly, and then the 3rd stage. Oh, I should have mentioned, same scenario, if there's an acute scenario going on after trauma, that kind of thing, then you can use the inflammatory protocol as well. Hip placements. So this is really important to access and get as much light in and around that superior anterior aspect of the hip joint. Try and have the patient position in the figure 4 spot. You can see that to the left here. This can be uncomfortable, so be careful with that. Prop up using pillows underneath the knee so it's comfortable for them. They may not be able to do this very well, so it's really important to try and do it as best you can as long as they're comfortable. You don't want to stress the joint too much and cause any pain. First position will cover directly over that anterior superior aspect of the acetabular region. Second position is over the lateral joint, and then the 3rd position is over the posterior aspect of the joint. I think that's pretty straightforward. And again, very similar to the shoulder joint, but in this case, the hip joint, when you're using laser probe, keep the hip joint in the figure 4 position. And then you want to press down. And by the way, I didn't mention this for the shoulder. When you're using the probe, apply pressure. Apply as much pressure as that patient can tolerate in order to get the tip of the probe closer to your target. That's the key. The closer you are, if you're within 2 to 4 centimeters of the labrum, guaranteed you'll get light in there. Guaranteed if you hold it long enough. Okay. So know your anatomy, know where the acetabulum is, know that there's muscles and other stuff in front of it. So that's problematic for the hip joint. So you're going to have to hold for longer. So how long would you hold it for? Well, the recommendations are anywhere from 6 to 12 joules per point for the hip joint. At approximately 180 milliwatts to 200 milliwatts for our laser probe, you're looking at, for 6 joules, about 30 seconds. And all the way up to 12 joules, about a minute per point. So start with half a minute, 30 seconds, and then work your way up to 12. If the patient's not responding or you feel you need to get more stimulation there, or pay attention to the size of your patient. Small, thin person, probably 6 joules is adequate. A large person, you know, that kind of scenario, then you may need to use more. You're going to start at 100% of the with the laser probe as well. Okay, so really important. This is how you're going to get light directly to the labral area. Now remember, you have to be realistic here, because a treatment plan, what's your goal? To heal it completely, a tear in the fibrocartilage? I'm going to say unlikely. I'm going to say unlikely. Will it be helpful? Will you get reduction of inflammation? Will you get some repair? Chances are yes, unless it's a significant tear that does require surgical intervention. I've treated a lot of hip and shoulder labral tears, and I've had good success, but we're not talking no pain, 100% resolution for many of these patients, because it's chronic, because it's significant. So let's be realistic with these patients, right? When they first come in and things are acute, then preferably treat consecutive days, 3, 4, 5 days in a row, if possible. I know these are all potentially issues. I mean, can a patient come in that realistically that often, or what have you? One option is to also rent a system to them, a personal system, come in using that in between treatments as well. Maybe reduce the cost a little bit for them, but they still come in for full treatments in the laser probe. That allows for better efficacy. You can have a few of these that you rent out. It does provide a return on investment as well. So keep that in mind too. So, rental programs, that kind of thing might be an option here for these types of progressive issues as well. Then after sort of that, if they're not in acute phase, kind of more chronic or lingering, then you can treat 3 times a week, every other day. 2 to 3 times a week is usually what's recommended. When they're starting to make fairly good progress, and I'll leave that up to you to figure that out. I mean, it all depends, right? Then you can go to twice a week and eventually once a week. How long this takes, I cannot say. Other than, in my experience, we're looking at months. That's the bottom line when you're treating something like this. Not a few weeks. I mean, is it possible? I suppose, but depending on the age and other factors. But oftentimes you're dealing with a longer time frame of treatment plan. So that needs to be taken into consideration as well. Don't forget, imaging can be really important to understand what's going on and the extent of the tear and degeneration, those kinds of things as well too. Of course, other treatment options are really important. I have seen good results and evidence with PRP. That's where you just collect the blood of the patient, spin it around, collect the platelets, and then inject it into that site. By the way, there's research to indicate that PRP and photobiomodulation are synergistic. In other words, photobiomodulation can increase the positive effects of PRP. Other options are stem cell injection as well. It's considerably more expensive, a lot more invasive, where you're taking usually from the bone marrow or the blood, that kind of thing, trying to isolate, grow the stem cells, and then inject it back into the patient. There is, again, some good research to show this can be very beneficial, but let's face it, unless you have a fair amount of money, or these patients have a fair amount of money, it's not going to be an option for many people. And of course, is surgery, right? Arthroscopic surgery, they go in and say on the right here, the shoulder, they have to drill holes to put an anchor in there, not like an anchor used for a boat, an anchor for the sutures. And then they kind of like just, thread it up. I know there's some really specialized arthroscopic surgery out there. I'm obviously not a surgeon, but I know they're having better and better techniques, but of course it really is limited as to when they would do surgery, whether it's a shoulder or their hip. I've heard of graft replacements as well from the patient's own, they graft it take it away from a certain area of the patient's own body, or even donor grafts. I don't know how successful those surgeries are. Okay, well, that brings us to the end of the webinar. Really, thank you for that. We have a couple of upcoming events: cervical spine advanced training in September and aging and cosmetic issues in December, if you want to join us for those. So far, I have Dr. Ben Ewan signed up for the cervical spine. I'm really trying to get Dr. Roberta Chow from Australia to also talk about her work. She's an amazing, amazing researcher and clinician. So I hope to have her confirmed. And that will be a really good event as well. All right, thanks for listening. Let's get to your questions.